speak to this audience about our experience during the last 4 years using a modular stem. And it's now an easy job for me because the most complicated formulas were already explained by Karl-Heinz Wittmer at the moment. So I walk over to the daily surgical job. So the targets of the patients and of us, of the surgeons, are the same. The patients want to have, first of all, no pain. They want to have a normal range of motion, a balanced leg length, a normal gait pattern, joint stability, and longevity of the implant. And especially leg length discrepancy and the limping gait is most disturbing for both of us, for the patients and also for the surgeon at the follow-up control. So most of the time, if we do our surgery in primary osteoarthritic hips, it's easy. We don't need special prosthesis. We can use standard prosthesis with a modular ball on a stem. So like this is a standard situation, and I would guess in our hands, in our population, 70 to 80% of the individuals have a quite normal anatomy. But on the other hand, there are some individuals like this one. This is a 69-year-old gentleman, and he has a very low CCD angle, and this characteristic bump osteophyte or cam osteophyte. And usually these individuals have also a reduced anteversion of the femur. And then it's not so easy to really restore the biomechanics of these joints regarding especially offset and leg length. So here you see we did use a modular, twin modular, ball and neck and stem, twin modular prosthesis, uncemented prosthesis with this Ananova stem. And we could meet the targets to restore the joint function. In contrast, this is a lady with a dysplastic hip situation. She had an arthroplasty work on the right side some years ago, and on the contralateral side, affected side, she had Chiaris osteotomy. Both procedures were done elsewhere. So we have to restore the joint function and to have also a good relation to the already implanted contralateral hip side. So if you template with a modular prosthesis, you see here on the left side, this is a modular neck with an 123 degrees CCD angle on the right side with a 130 degrees. And the difference is minimal, but with the 130 degrees neck, you can restore the leg length better than with the lower CCD angle. And that is what we did. We did use the higher CCD modular neck in this individual situation. So many factors are influencing the result of our arthroplasty work, especially positioning the socket more to the medial, to the lateral, the abduction of the socket, the anteversion of the socket, and also what Karl-Heinz Wittmer already stated, the anteversion. I think the anteversion of the stem was, I would say, 2 decades neglected, so to speak. And it's very important also to bear in mind also the features of the head-neck ratio. The offset is not only depending on the CCD angle of the neck you use, it's also depending on the anteversion of the stem you use and the neck length. And then, and we come to the minimal approach, very important is for sure is the approach you use. Simini was declaring also that at least 135 degrees of oscillation angle, or the angle theta, is necessary, 135 technical range of motion to avoid impingement and to get a good range of motion. And here's the Widmer formula again. The combined antiversion is the socket antiversion and the stem antiversion multiplied by the factor 0.7. And very important was also the paper of Widmer regarding the CCD angle, and the optimal CCD angle should be in the range between 125 to 130 degrees. And if you change, as Karl-Heinz, I apologize for some repetitions now, and what he stated is if you reduce the CCD angle about 1 degree, you have to increase the antiversion of the socket about 2 degrees and the adduction about 0.5 degrees. Also, Yoshimine combined the abduction of the socket and the antiversion of the stem. So he calculated that abduction of the socket, antiversion of the socket, and antiversion of the stem should have the sum of 84.3 degrees. A very interesting paper was published by the group of Müller from the Charité Clinic in Berlin. And they did examine a group of patients after total hip arthroprosthesis with CT scan and 3D reconstruction. And they could evaluate that the anterior tilt of the stem in the femur is usually about 5.2 degrees with a range of almost 0 to 9 degrees. And they had also a mathematical model and calculated the antiversion which in the stem, which the surgeon gave to the prosthesis and to the femur. And this was on average 8 degrees of antiversion in the stem, so to speak, added from the surgeon. And this has a very wide range between minus, so retroversion of 11 degrees to antiversion of 26 degrees. And with this mathematical model, they calculated that the functional antiversion is 18 degrees in this group on average. There were different surgeons, and so the on average antiversion in the femur of the prosthesis was 18 degrees. So if we would bear that all in mind if we start surgery, we have two possibilities, as already was said, stem first technique. In our country, usually most of the surgeons implant the socket first, and secondly the stem. Reinhard Graf probably is well known because of his work in sonography of the hip joint. He invented his own mechanical socket navigator. So he inserts the stem, and then he does a trial reduction using a mechanical navigator, and this navigator indicates the position of the socket, and then he implants the sockets like this. He shows very often dramatic follow-up X-rays with sockets with an extremely high abduction angle. And therefore you need a modular socket with a wide range to set the inlay into the socket. Otherwise, you have an increase of wear because of micro separation, and you run into the risk of dislocation, stripe wear, squeaking, and so on. So most of the surgeons in our country prefer to insert the socket first and then the stem. If you implant the socket, you use anatomical landmarks like the transverse acetabular ligament, and it's very often difficult if you have a severe dysplastic deformity or you have a pincer type socket, then the landmarks are not very precise. You can use mechanic navigation, more and more electronic navigation, or fluoroscopy. So at our clinic, we have been using a very simple mechanic navigation device for more than 35 years. And we usually target an inclination of about 40 degrees and the anteversion of the cup about 13 degrees. This is the simple device. First of all, we pin 2 K-wires in the anterior superior iliac spines, and then we have, during the reaming and the insertion of the socket, we have these goniometer on the pelvis fixed on the K-wires, and we have the goniometer, and then we have this water level, and the water level, the lever arm of the water level is tilted from the room horizontal about 13, and you can vary, you can use 15 or 17 depending on the individual. Here you have these 13 degrees of inclination during reaming. We always have the patients on the supine position, and these are the 2 guides, the goniometer for the 40 degrees and the water level for the 13 degrees. We did control a series of 164 individuals retrospectively, and there were 2 groups. The left bar is only 2 surgeons doing prospectively an ANOVA modular stem, and the others, 8 surgeons from our clinic, they're doing routinely SL-MIA procedure, non-modular stem. And we ended up, regarding the anteversion, the target was 13 degrees, around 13 degrees with a standard deviation of 3 degrees. And with the inclination, it was quite different. So we targeted 40 degrees, but we ended up usually much higher with 47 degrees in both groups and a standard deviation of about 4 degrees. So if we fix the socket in this way, it's very wise to have a modular neck, because then we can orientate and adjust the stem to the fixed socket using this modular stem. And this is very easy to use. It's really an easy to use device which Karl-Heinz Wittmer invented. These orientating trial balls which are available for the different angles of the modular neck, and you can control the angle of the CCD and also of the ante or retroversion. So here we always are using an anterolateral minimal invasive approach. Here is the ball on the neck, and here we have to control if the Wittmer rings are really parallel to the entrance, the opening of the socket. So in our experience, these modular necks are very nice if you do a socket first technique to restore the geometry of the joint, especially in those individuals which have a very abnormal anatomy regarding the CCD angle and also anteversion and retroversion. As I mentioned, with the first individual, the second individual, I did show you with the sportive gentleman having a very low CCD angle and usually a reduced anteversion angle. And it's also easier with this socket first technique by using these trial balls, which Wittmer invented, to really adjust the modular prosthesis, which type of modular neck you select, and in which position you use the anteversion. There is no advantage without the disadvantage, and the disadvantage for sure is if one of these modular is really breaking because of this corrosion. And about this complication, Frank Rauhut will speak later on. Thank you very much.
Thank you very much, Uli, for a very well-documented lecture. And